Welcome to Health System CIO's interview with Dr. Peter Pronovost, Chief Clinical Transformation Officer with University Hospitals. I'm Anthony Guerra, founder and editor-in-chief. Peter, thanks for joining me today.
Anthony, it's great to be here with you.
All right, great. So you want to start off by telling me a little bit about your organization and your role?
Sure. So, University Hospitals in Cleveland is about a $6.5 billion health system. We have around 22 hospitals, 32,000 employees, about 60 primary care sites. We have an ACO that has about 800,000 people in it, and we largely serve Northeast Ohio. And so we have a nice geographic community that we uh, care for. In my role, I'm the Chief Quality and Clinical Transformation Officer and the president of the VO Healthcare Transformation Institute. So I run our ACO to try to improve performance. I oversee quality and delivery, making sure it's high quality, it's safe, it's patient centered, and it reduces waste. And then the Transformation Institute is where we pilot, test, and deploy technologies or other solutions that are innovative to try to help improve value. But all of them, Anthony, or all my work is geared around kind of driving us towards zero harm, zero physical harm and complications, zero suffering, such as from delayed access or disrespectful care, zero waste, and then zero inequities, which is any group having worse health outcomes than another. How do we make these defects in value visible and then get rid of them?
Yeah, of course, that takes us into AI, which we're not going to do yet. We're not going to go into that right now. But when you talk about inequities, that's one of the big pillars of implementation of AI, right? Equity, do no harm, all these kind of things. You want
Correct.
to make a quick comment on that and we'll go into the other stuff?
No, let's go into the other stuff. I don't want to distract
Oh,
us.
perfect, perfect. Yeah, AI pulls us in everywhere, but appreciate you staying helping me stay focused. The Lake West facility whole hospital remote care platform. So you recently wrote about that. Why don't you tell us a little bit about how that facility fits in with the overall organization, and then what this program really is, and we'll talk more about your plans. I assume to scale it out to other facilities, but wherever you want to jump in there and just tell the folks what this is all about.
Yeah, so Anthony, let me just frame this by what problem we were trying to solve with this, because there were several of them. We said healthcare still costs too much, so we have a labor problem, and we, have a framework of saying, hey, what could we either stop doing? If we can't stop, could we automate it? If I can't automate it, could I outsource it or do it remotely for with higher productivity? And what stays sacred at the bedside? And so that was enormous amount of tasks in there. We also know we don't reliably to do tasks. And then importantly, Anthony, we have nursing staff who are burdened and junior nurses that feel safe caring for two patients, but most of their assignments are five. And so without having some support, they often get overwhelmed and their turnover is high. And so we launched a pilot prior to the Lake West where we took 5 units across our health system and ran a single unit pilot to get the kinks out with this system to see how it could work. And the way we did it, Tony, was I think kind of novel, meaning the nurses who were doing the remote nurse were from that unit where they work. So they would rotate a day or 2 days a week in what we call the command center, and then they would go back on their floor. And what that did was build trust with the nurses that the remote nurse was capable and caring and part of their team. But we housed these 5 units together so that each of them could learn from each other. They had a little bit different workflows, but they, shared new use cases or how things are going. And so though we saw that if we added a whole hospital, it would just unleash a whole number of use cases. So, for example, social work could use it, care managers could use it, physicians could use it. And so, this was our first effort to launch a whole hospital. And it is just mind boggling the innovation that it is unleashed, Anthony, because as staff see this literally every day, they're coming and saying, oh, Peter, what if we did it for this? This could add more value, and we could do that for this. And what it, as you as a CIO and your audience, it started making me think about, do we have transformational technologies that match a model of transformation like we are deploying. We call our transformation model living and leading with love. And our transformation model simply says that all people are worthy and capable. So we want them to innovate, that everyone's voice should be heard so they can contribute to make things better. And we build discipline management and accountability systems. And so we innovate really fast. This technology, when we literally have staff coming up with ideas, we could build it or deploy it the next day. And we're seeing if it works, in 2 or 3 days, because we have enough patients, and then we either spread it or add it. It's a super exciting time for finally making healthcare closer to zero harm.
So, some of the general ideas here are we create an environment where people are encouraged to innovate and do things differently. We provide them with technologies and that allow that or that foster that. Uh,
Correct.
and then we teach them how to use the technologies. And this is what I've been saying a lot about AI. Um, and sort of one of the general ideas here that we see at a lot of organizations that I think is the successful way to go is educate the implement the tools, put the guardrails around them, educate the workforce on what the things they can do, and let them go solve their own problems. Because you're never going to know from up high the nitty gritty of what they're dealing with. The key seems to be just to put those safety guardrails in place, whatever you consider those to be. It's almost like, and I hate to use the example, but when you're giving children toys, you make them safe. You take the hard edges off, the sharp edges, and then you go let them be creative. So there's a little bit of that there.
Yeah, and so you're spot on. And what we think about, Andy, is we have both a management system that is, we do need goals and metrics, but those are often static, and work is too dynamic. It changes in real time. So we need a much more flexible and dynamic work system so the teams on the units could figure things out together. They could innovate when they work, that they spread. So these kinds of technologies just help foster and unleash that innovation, because all throughout healthcare, most of our clinicians are really innovative. They have
Right.
ideas, and it's frustrating for them when they have an idea and they get told, well, yeah, it's going to be 6 months to add to our EMR, right? Or it's a year to add, or no, we can't add that. It doesn't fit our priorities, and they get frustrated. Like, yeah, but this will make a really big difference. There's harm going on. I think we can improve it. And so finding that balance, as you said, we need guardrails. I think well done management systems provide that, but we also need to unleash the brilliance of the people who are closest to the work to figure things out.
I think that's 100% right. I was speaking to someone the other day. Had to do with they were sort of the spot where sort of AI requests and AI tools were coming, and they could see that it was centralizing sort of an approval process or review process wasn't going to work. It wasn't going to scale. Things are coming too fast, too furious. So bottlenecks, when you need speed and innovation, bottlenecks are a killer, right?
That's
So
exactly right. And like in my view, because I think a lot of health systems, like you're saying, are struggling with, oh, I have this fear for AI, and perhaps there's some legitimate reasons for fears. So I'm going to centralize it and control it, like the Soviet economy. That doesn't work very well. And I think what we have to say is like, AI is going to be part of every role. Like, I mean, like you can't, it's like, stop thinking it is something foreign. It's just another tool that literally, no matter what you do, it will be embedded or already is embedded if you're even aware of it in what you do. And so how do we then see that as an accelerant and a companion to do our work better with the appropriate safeguards and guide rails, rather than, and so seeing it through the lens of abundance rather than scarcity and fear.
yeah, and I guess sort of, when it comes to generative AI, the education part is making sure people understand that it's not going to be perfect every time. It's not going to give you the exact right answer every time. It can help in a lot of ways, but it's not infallible. So that's an important part, right? Educating when you give them these tools, educating them on caveats and things like that.
But without a doubt. But humans are fallible too, right? That's my career in patient safety. One of the biggest challenges is just helping clinicians recognize that fallibility is part of the human condition. we don't change the human condition. We build safeguards so we make those mistakes visible so we can prevent patients from being harmed when they do occur. Right? And I think it's very similar to AI. Like the AI is going to make mistakes just like we make mistakes. And then the question is then how do we be diligent and make sure that we're visible so that we intercept them before they can go wrong and harm patients.
And I totally agree with you with the concept that we shouldn't be comparing it to perfection. We should be comparing it to improvement, which it certainly does. At least it improves my performance in just about everything I do.
Yeah,
Uh,
same with me. And Anthony, we need to recognize that. I mean, just take the work and harm. You know, the best data we have shows that about 1 in 4 hospitalized patients are harmed. There's been 2 OIG studies that show it's been that way for over about 15 years. I mean, it's almost stunningly 1 in 4. We know we waste, about a third or more of every healthcare dollar we spend, well over $1.5 trillion, $1.5 trillion because of inefficiencies. And we still have delayed access and so there's a whole lot of ways healthcare could and needs to get better. And I think AI has an enormous potential to do that.
yeah. So let's talk about the idea of governance and parsing ideas. If let's say we put some cool tools out there for people to use, we educate them on guardrails and safety issues and how the tools can be best used. And then you mentioned a very important concept earlier that's also part, I think, of this whole best practice flow, which is disseminating ideas that work. So there's got to be some kind of ideas. People do things, ideas bubble up. Some are proven out, some are not. The ones that are proven out, and I've heard of people publishing things like promptathons for competitions, and then the best ones sort of get published out in prompt libraries. But it doesn't just have to be prompt. It's just the concept of everybody trying cool things and being innovative, figuring out what's working, and then disseminating that idea to the larger population.
Yeah, Anthony, let me just share with you because in our transformation model, um, very shortly, I mentioned it says all people are worthy and capable and that everyone should be able to contribute. And then we have discipline management systems. But for that, everyone can contribute. We use the concept of a fractal. So I don't know if you're familiar with that. So fractal are ubiquitous structures in nature. Fern are fractal, snowflakes, flowers, are alveoli, or capillary. They're all fractal. And fractals are simply identical shape but varying size structures. And they operate by simple rules. And so we build a fractal for every project that we do across our health system. And it simply means, or our rule is every higher level of the organization needs to have a table where every lower level has a seat. And if that table gets too crowded or there's too many branches on the tree, add a new branch. But we don't have dissemination of best practices by chance. We build a structure or the scaffolding to allow it to flow. So some of our ideas come from our smallest hospitals or a rural
Right.
hospital, but they're at the table and we have a mechanism, this structure that allows the flow. And importantly, a culture that says it's safe to speak up or you don't need a pedigree to have good ideas. They can come from anywhere, and so I think you're right that we need a governance to make sure that these things that are working and don't work
Right.
rapidly flow, not just through the organization, but I would say even more broader healthcare writ large.
Oh, yeah. So you've been thinking beyond your organization. This idea of everyone has something to say. I mean, part of leadership is getting people who feel, insecure or like they don't have something to say or intimidated by some of the pedigree of the folks around them. They may have a great idea, but you have to draw it out of them. You have to help almost make them feel comfortable and safe.
Got it, got it.
Some people have been through difficult experiences with other employers where their opinion was not valued, and you're shell shocked in a sense.
Right,
So
right, right.
this is all part of leadership and management. So it's not simply putting up with or encourage. It's more than that. It's drawing it out. And what are
That's
your thoughts?
Anthony, I'll share with you, and your audience may like this. They could feel free to do it in their organization. I share with all of our staff are and doing at leadership meetings this story of the flea in a jar. And so the story is really quite simple. If you put a flea in a jar, it will immediately jump out. They don't like being constrained. But if you put a lid on the jar, they'll bonk their head maybe twice, and then they learn not to jump high. But when you take that lid off, they will never jump out of it again. They've been conditioned not to aim high because like their voices aren't heard. So I share that and said, how many of you feel like a flea in a jar? And Anthony, it's and literally every hand in the room goes up, and including VPs or C-suite level. I'm like, whoa, whoa, like think about the dysfunction here. Why would we dismiss this brilliance and this innovation that's unleashing by making people be like fleas in the jars, right? We have to evolve this command and control mindset in healthcare towards unleashing and inspiring people to have their ideas valued and included.
All right, so we're gonna go a little bit off track, but I'm having fun with this. Um, let's talk a little bit about leadership. And what I'm struck by, and I've written a little bit about, is the disconnect between what we know to be good leadership, what people say is good leadership, and many, many people's experience of actual leadership in the workplace. So m- many, many people I speak to in my personal life, in my work life, have bad experiences with leadership, but everybody seems to know how it's supposed to work. There's a disconnect there. And what I think it is, I think in the real world, there's a dynamic where there's certain people who are very good at managing up, and therefore they're very good at moving up, but they're not very nice to work for. What are your thoughts
No,
around
I,
this
I, I
dynamic?
think you're absolutely right. I mean, well, you heard my this model I believe in of living and leading with love, and it's very much of a servant leadership. Like your job is to help solve problems that make the world a better place. But too often, people get rewarded for being bullies. They may get results.
Right.
Oftentimes, they don't. It's a myth of result. Frankly, either short-term results or they have negative consequences. But that we tend to still think of the alpha male if they show power that they get promoted. And I think you're right. I mean, healthcare and industry in general is riddled with people who uh, don't have great leadership behaviors. They could, and we know from the literature that good leadership and management matters immensely. I mean, not just in organizational performance, but in the happiness and joy of the people who work there also.
Do you think healthcare is so part of I think of being in a positive environment is change, right? Because when something's not working, when someone's not working out, when someone's bringing some negatives into the workplace, change can be necessary. You could always say we could coaching and things like that, but is healthcare so averse to change? Because we hear about people being in positions 25, 30, 40 years, which can be really good. But I wonder if you think that's part of sometimes why these environments aren't the most conducive to perhaps happiness of some employees, is because there's such an aversion to change that necessary change sometimes isn't done.
Yeah, so I think there's an aversion um, to change, but let me just, I would probably, Anthony, just dig deep in that to say, I think there's an aversion to loss, not change. And but so if I were to give you the lottery ticket that paid $1 billion, it would probably change your life pretty dramatically, right? And you would never say to me, no, no, Peter, you keep that lottery ticket. I don't want to change. Change is bad, right? So like what it is change is good, bring it on. It's when there's a loss associated with the change, and that's either power or stature. But one of the losses we see in leadership all the time, Tony, is people are not comfortable having an honest conversation, right? Like,
Oh yeah.
just giving feedback to say, hey, Tony, like you're doing your job, but the way you're working is bullying people. It's not acceptable. And, here's what we're going to need to change. Too often in healthcare, we don't have those conversations, until, they explode or something and someone moves out. And even then, there's often not a feedback or a coaching session to explain why. It's just, someone got fed up or they had enough. And so I think, you know, part of this is more authentic feedback and having honest, crucial conversations with people about how they're behaving and how they're working.
Sure, and most people want to avoid that like the plague, like you said. Most
Correct.
leaders don't wanna have those conversations, but it's such a problem when everyone on the team knows there's one issue with one person and the leader won't address it. And I've worked for people where the biggest issue was that they didn't seem to address problems everyone knew about, and because they didn't wanna have those conversations.
Yeah, and it's demoralizing and
Yeah.
trust breaking for the whole team. I mean, and even if they're an excellent individual contributor, uh, Anthony, the net effect on the organization is almost always negative, and that's whether they're a high volume surgeon bringing in a lot of money, but they don't behave well, or they're an excellent performer in the IT department, wherever it is. Um, uh, so I think a much needed is clear leadership skills, clarifying the principles or the behaviors that we want in our organization, and then making sure that we uh, are accountable for them or have shared accountability to have conversations when someone's not performing on those and celebrating when they do.
Yeah, and you mentioned surgeons and things like that, and that's, probably in every industry, there's individuals that, uh, are of a certain status that perhaps they can get away with things, to use a poor term, but, we know that happens in healthcare. My wife's a nurse practitioner. We know that happens in healthcare, but again, that's a part of addressing issues, right? They have to be
That's
addressed with
exactly right.
who, no matter who's doing it.
And Anthony, you may remember in aviation, um, they had the same issue with pilots. Pilots are very hierarchy, and there was a very famous plane crash that when a flight went down into the Potomac River in Washington D.C. and the cockpit recording was it sounded something like this: the plane was late. It was like on a Friday afternoon before Christmas. Passengers were frustrated. They wanted to get home. It was right on the freezing point, and they were deciding to de-ice. And
Right,
the captain said, "Okay, we're not going to de-ice." And then they start rolling down the runway, and the co-pilot says, "Wings are boggy," meaning they have a lot of weight. Says it again, no response. "Captain, wings are boggy." "Captain, slow on approach." "Captain, we're slow on approach." "Captain, we're not going to clear takeoff." "Captain, abort takeoff." And the plane crashed. And NTSB heard this and said, we've either selected for deaf pilots or we have a huge culture problem on our
yeah.
hands, right? Because they were speaking, but they weren't being heard. And so they simulated and looked at other things, and they indeed found that they had a very hierarchical cultures. So what the co-pilot said was viewed as not relevant or less important and was just categorically dismissed. And their response was mandatory crew resource management training or teamwork training so that anyone's voice could speak up. And we're not there yet in healthcare. We made some progress, but we still have you know many places or roles where they feel they can't speak up, or if they speak up, uh, they're not going to be listened to.
So it's an interesting story. And I remember you wrote a lot. You've done a lot around checklists, correct?
Correct.
I
I
remember
do.
that from a few years ago. And I was thinking as you were telling that story, and I'm a huge fan of checklists, and my kids will tell you I'm obnoxious about it because I'm like, where's your checklist? Like, especially when you forget, so you forget to take this to school, you forget to take this to practice. Make a checklist on your phone.
That's
What's so hard
exactly
about
right.
it? People always have too much confidence in their brain. That's the problem.
Yeah,
Um,
it goes back to my message earlier. Is if once you accept that fallibility as part of
yes.
the human condition, there's nothing wrong with it. We're going to forget. Make a checklist.
That's it, I'm with you. I don't know, maybe I'll get you on the phone with them. But what's interesting is the pilot story you just told, that wouldn't be solved by a checklist. That dynamic you mentioned of the
Correct. No,
pilot
that's exactly right.
ignoring,
Yeah,
that doesn't so the checklist solves a lot, but there's things that it doesn't solve, and
yeah,
that's one
it's
of
the
them.
relational part. Or you can try to do something that you could have a requirement, for example, that you read back if someone says something to you. So in that case, the pilot didn't read back. It could have been the pilot or someone else in the cockpit could have said, "Captain, I asked you a question, you didn't respond. Please respond."
That's fascinating. Did they die, the pilots?
I don't remember if the pilots died, Anthony.
'Cause I would have loved to hear that debriefing of the pilot, being asked, "Did you hear him? You didn't respond. Did you hear him and choose not to respond? If you heard him, why didn't you respond?" And it may have had something to do with that specific relationship. Maybe they didn't get along, maybe they had a fight, maybe they had a bad experience prior, right? Fascinating if you could get into the weeds on that.
Yeah, exactly right. There's some data that, again, thank God, plane crashes are quite rare, but that previously showed about 80% of crashes occur the first time the flight team flew together.
Ah,
Because if you know each other, you kind of get to know each other idiosyncrasies, like, what do I got to do to get Anthony's attention, or what does
yeah.
Anthony got to do to have me hear him, or I may trust you more. And so it's a fascinating statistic.
Yeah, and it makes me think, I don't know if the NFL does it anymore, but they used to for the Super Bowl, instead of taking the best crew of officials, they used to make an all-star crew of officials. And people were like, "That's a bad idea. You're taking a bunch of guys who haven't worked together before and haven't
Correct.
worked together."
Yeah.
By the way, it made me think when you're talking about the story of the pilots, I'm sure you've looked at some books on Chernobyl, and there's some great books that go into that disaster and the actual nuances and the specifics of the sequence of events. I
Yeah,
mean,
it
just
sure is.
fascinating. So, good stuff. Let me just ask you a final couple questions. We'll get a little bit back on topic, sort of, but change management. Let's talk about that. Just this concept I've talked to people about there's a max capacity for change, and that doesn't just go for an organization. You have to drill down and get very specific. For example, you're not talking about a university hospital. You're not even talking about the facility. You'd be talking about a unit, you'd be talking about a person. So, people were saying that in order to really make sure you're not overwhelming a unit or a group or something like that, you have to have really good intelligence and information about what's going on with them, what has gone on with them recently, implementations and things like that, and not just IT related. There could be other change things that are going on in other elements of their work life. So you have to study all this and have some understanding. Otherwise, you could overwhelm people. What are your thoughts there?
Yeah, so I completely agree. And just, one of the metaphors we use that I really helpful, it's the concept of a pressure cooker, right? And
Right.
organizations can only take so much pressure. And how do you find that local pressure and know that if it's low, you may be able to turn it up and get work going faster. If it's blinking red, you're going to have to back down and lower the temperature and pressure because it's going to explode. I think it goes back to my respecting individual people. The only way you find out about that, Anthony, though, is you listen to people, you talk to them, and if they say that we can't absorb anymore, you try to unpack it and understand um,
Yeah.
why they're saying that. Because if you assume positive intent, you're going to believe them. But too often we don't assume positive intent. We assume I'm right, you're wrong, and you're just lazy. You don't want
Oh,
to
yeah.
change, so I'm going to bully over
Right.
you with this. And we often wreck uh, havoc. And we live by this mantra in my organization that is change progresses at the speed of trust. And
Oh,
trust
yeah.
grows when we do things with rather than to people. So
Yeah.
change always needs to be a dialogue with the frontline people to say, hey, I think this is why we're doing something and what the goal is. Now let's figure out how. And part of that how might be there's no way I could absorb it, Peter. I get we'd say, okay, well then what do we take off your plate? Or this is really
Right.
a priority. I get we need to do it. How do we give you more resources? But that kind of dance and dialogue, is needed and too often absent.
All right. Well, Dr. Pronovost, I could keep you for another half hour. You're a lot of fun to talk to. Um, but I'm going to let you go. I'm sure you got other things going on today. So this was wonderful, really valuable, enjoyable. And I want to thank you so much for your time today.
Sure, thank you, and best of luck.
All right. Have a great day.
You too. Bye bye.